Thanks, Mo.
Thanks, Nancy. Super grateful. Um, I would like to thank each and every one of you for giving me the opportunity to talk about something that is really close to my heart, something I absolutely love doing and talking about. I'm also grateful that you've given me the opportunity to be a part of your online classes amidst this pandemic. So without further ado, let's do this, shall we? Okay. So before I start, I would like to throw this thing out. In my opinion, or as per my observation, I've seen there are two things or connotations associated with not all, but a few periodontists, which is again my observation, which is arrogance, and they tend to overcomplicate things. Oh, I should have not touched my nose, but it's okay. So, so they tend to overcomplicate things as well. Why do they do that? Again, my observation, I think the reason is that it makes them look awesome. And the other reason is periodontists are considered plastic surgeons of the oral care. But anyone who knows me or who has seen me work would know that's not my style. I just like that. And I like to make things super easy. The other thing is, if at any stage you find me arrogant, please feel free to tell my mom. She would make sure I get a super awesome beating. Okay? So let's get into it. Now, a little bit about myself. I was, like Nancy mentioned, I'm grateful. I was born, brought up, and raised in beautiful Pakistan. Did my basic dentistry from there. And then I got the opportunity to be accepted. I was accepted at McGill University, did my first master's at McGill University. It was a very good experience, spent about 1.5 to 2 years there. Once I finished the program, almost at the very end, I was accepted at the University of British Columbia. I did my second master's at UBC. I also did my 3 years surgical training, is residency in periodontics and surgical implant dentistry from UBC. It was known as Diploma in Periodontics. Once I finished with that, then I did my fellowship at the Royal College of Dentists of Canada, again in periodontics. And to cap it off, I ended up doing the Diplomat of the American Board of Periodontics and surgical implant dentistry. Once I had done that, I moved to Edmonton and I wanted to improve my IV sedation skills. So I did my certification in the IV sedation at the University of Alberta. I was also doing my private practice in Edmonton area. I did that for about 2 years. Another thing was, which I absolutely love doing, and I absolutely love doing it to this day, and hopefully I become more dedicated towards it as the years go by, is teaching. I taught at the undergrad level, which is DMD DTS, both at the University of Alberta and University of British Columbia. But the thing that I absolutely loved, cherished, and enjoyed was teaching at the graduate level, which is the residence periodontics. Then I moved to Regina in December of 2018. That's when I started Regina. And now I work for about 3 weeks every month in Regina, and I work for about 4 to 5 days, which is a week in North Alberta. Absolutely love my both offices. People are there, and a shout out to all of you are awesome. Hey, now let's do this. So this is a list of procedures which are commonly done or routinely performed in a periodontal office. Nothing fancy, simple procedures. But given the time constraint, we will be focusing on dental implants, the surgical aspect. I'll try to touch upon the surgical aspect of dental implants. I will also be talking about associated procedures which are associated with the surgical implant industry. My goal will be to make it super simple, super easy. I will try to bring it to the level so anybody who has zero knowledge of surgical implant dentistry or very minimal knowledge would be able to or should be able to. If I fail in achieving this objective, then I fail as a teacher. And if you have any questions at any point in time, please feel free to ask me. You can ask them at the end as well. Whatever works for you is fine. Let's move on. So what are the procedures which are associated with surgical implant dentistry? We can say that there are basically 3-4 simple procedures. One is called a socket preservation. What is a socket preservation? Socket preservation means if you have a tooth You extract the tooth, you remove the tooth. What is left is the socket. Inside that socket, there are some soft tissue and hard tissue. Now, based on literature, what I'll do is actually I'll just quote it once. I don't like to, I'll try to make things simple. But when I say literature, there are good studies, scientific studies, which have shown what some things, which I'll just refer to as by saying literature. So in this case, I'll just say, for example, Shroop 2003 and Lekovic, I think, 98, they've shown that if you remove the tooth from the socket, this socket can shrink and collapse up to 50 to 60% in this dimension, which is horizontal dimension, and maybe 1 to 1.5 millimeters in vertical dimension. So one way to try to minimize that shrinkage is by socket preservation. The technique is you have a socket, you remove the tooth out. Now this is an empty hole. You fill this hole with bone. The bone we use traditionally these days looks like table sugar. Actually, just looks like table sugar. Where do we get it from? Costco. Just kidding. We get it from London Dry. Not even London Dry. There are bone banks. We go to the bone bank and we just buy that bone. And that bone looks like table sugar. So we fill this socket in with that table sugar, if you will. And that's pretty much the simple concept. In other cases where, let's say, we are missing it, it's an edentulous where there is no tooth. Okay, we want to place an implant. One key principle is if this is an implant, you want the bone to be surrounding the implant from all aspects. But let's say we have a situation where a tooth is missing, we want to place an implant, and we place the implant like this. So if you look at from one side, this is my implant, it goes inside the bone. You look at from one side, looks like, oh wow, there's a lot of bone on the outside. Good. But you look at from the other side, oh no, there's no bone on the other side. My point is, in some cases, we don't have enough bone to place the. What do we do? And the tooth is missing. All we do is we try, regenerate, create, add some bones with it, then we place the implant. That's called guided regeneration, GB. Another procedure is indirect sinus lift. What is indirect sinus lift? And you will get a better understanding as we reach these topics. But in a nutshell, what is indirect sinus lift? Indirect sinus lift is, we all know we have sinuses in the upper right side. For example, in my case, let's say this is my sinus. Let's say my sinus is from here coming all the way up to here. So I will call this part of my sinus is the floor of the sinus. If I want to place, and sinus has air, if I want to place an implant like this, my implant, the upper part would be hanging inside the. What can I do to create some bone in this area so my implant is not hanging inside the air and it's completely surrounded by bone inside the sinus? One technique is called indirect sinus lift, the other is called direct lift. I'll go into more detail to reach those. Okay, let's move along. So let's start with the socket preservation. What is socket preservation? How do we do it? Like I mentioned, we just extract the tooth. Somehow we just pluck the tooth out. Once the tooth is out, now we have the empty socket. We clean this up. Once it's cleaned thoroughly, we add some table sugar, which is bone in the area. Now, think about it this way. This socket has a lot of table sugar inside. If I'm the patient, I move this way, that way, or I'm playing soccer or whatever, there is some chance that this table sugar can spill out. I don't want that. I want that table sugar, which is bone, to be localized into this socket. How do I? One way is I take a piece of paper and I put it on top of the socket. So the lid, if you will, is closed. The bone cannot get out. What is that piece of paper? We call it a membrane. Now, academically, it's not true, but I'll just say it a piece of paper, and you'll see it looks like a piece of paper. It's made of collagen, or sometimes it's made of something else, but it's not dissolvable. It could be dissolvable, but to make things simple, you can think of it like a piece of paper. So if this is your socket, it has the table sugar, there is a piece of paper on top of it, so it's completely closed. Okay? What do you do next? Sometimes you just close this socket completely. Sometimes you let it be as it is because you have the piece of paper covered top. So I will not go into details where you do what, but the basic concept is you've extracted the tooth, there is an empty socket, clean it up, you add some bone in the area, you fill it up with a piece of paper, which reminds me there is a second advantage of piece of paper. Now, if this is the socket, it has this bone, which is like table sugar, and you put the piece of paper, the first job is that piece of paper will confine the bone inside the socket. There is a second benefit. If you look at the biology, the gum cells, the gingival cells or the gum cells, they tend to grow at a faster rate. So they creep up slowly, slowly. Let's say they're able to achieve a certain distance in 5 days. The bone cells, on the other hand, may take 6 weeks. And the final product formed by the bone cells, which is bone itself, takes about 6 months for final maturation, generally speaking. So that means if this is your gum cell and this is your bone cell, the gum cell can grow faster than the bone cell. Now, coming back to our example, this is your socket. On the sides of this socket, we have the gum cells. Now, if we don't do anything, the gum cells can slowly creep inside the socket, forming gum. Whereas we want to have bone inside because we want the implant to be surrounded by bone. How can we, and we already know that the gum cells, they tend to grow at a faster rate. What can we do to prevent the ingrowth of the gum cells into this socket, which will give enough time for the bone cells which are inside the socket to form? This is where our memory, so the piece. The benefit is this thing would not only localize the bone, it will exclude, it will prevent the gum cells from going in, facilitating, allowing enough time for the bone cells on the inside of the socket to form bone and make sure we have a ton of bone. So that's another benefit. Where do we typically use this technique? If there's a single tooth, sometimes two teeth, which are failing and we want to place an implant down the road, we extract, clean the area, pack the bone, close it off. This is where we use it. Like I said, as you can see on the screen here, the implant option is down the road plan. Another thing is immediate implant is not possible. What is an immediate implant? Again, simply meaning, let's say patient is missing tooth number 1. Patient comes to me and says, Mo, can I get an implant? Yes, you can get the implant. When will you do the implant? I do my exam, whatever I do, and I figure out there is just not enough bone to place an implant at the time of extraction. Yes, that means in certain cases, if there are certain criteria, forget about what those are, but if there are certain conditions, we can extract the tooth and we can put an implant immediately at the time of extraction, hence the name immediate implant. And we can just pack the area with bone or whatever. But in cases where we cannot put the implant immediately at the time of extraction, like I mentioned in the literature earlier, that the socket tends to collapse 50 to 60% in horizontal dimension. We don't want that because that will make implant placement down the road difficult. So how do we mitigate that? We just add bone in the area, let it heal for 5-6 months, then go back and place the implant. Also reminds me of another point. I just said you add the bone in the area, let it heal for 5-6 months, and then place the implant. Remember in my example earlier, I was saying it takes about 5 to 6 months for the bone to mature properly. May take longer, may take shorter, but generally about 5 to 6 months, generally speaking. And that means in certain cases, when you cannot place immediate implants, you add bone in the area, you let it heal for 5-6 months, then you go back. Okay. The indication would be that at the time of extraction, you also want to pack bone on the adjacent teeth or sites. Or sometimes patients are indecisive. They say, you know what, Mo, I don't know if I'll get the implant or not, but I want to make sure, regardless if I get the implant or not, I don't want my gums to look collapsed. I want them to look aesthetic. In those cases, we sometimes add. Okay. Now, to make it more easy and understandable, I'll have a sip of coffee. Just kidding. What I'll do is I'll use example. Okay. So let's do this. So first case coming up. And one more thing. One of the cases I'll be one case is I would like to give a shout out to my colleague. Actually, he was my senior at the residency, Sebastian Dostie. One case is, if I remember, I'll mention. Otherwise, if I forget, thanks, man. One case was partly done was by him and partly by myself. Everything else was pretty much, these are my cases. I did them, some in residency, some after uh, early days in my private practice. But generally, I'll show you the cases. Okay. Now, what you're looking at is tooth number 36. Okay. This is the buccal side. Looks okay. Doesn't look bad. But some funky thing is going on the lingual aspect. So I did my exam, whatever I did, I figured out tooth has a vertical root fracture. Now, when the tooth has a vertical root fracture, generally speaking, the tooth has a hopeless prognosis, which basically means that the tooth needs to come out. So this was the plan. We will take the tooth out, clean the area, pack the bone. In other words, we'll do pocket augmentation. So what you see here is the tooth has been taken out, section divided into each piece. And this is the bad tissue, granulation tissue, make it simple, bad tissue, nasty tissue, which was taken out along with the root. How does the socket look? This is how the socket looks, okay? This is the occlusal view. If I'm the patient, you're standing on my right side, I open my mouth, and you're looking at this way, okay? This is what you see. Moving on. Like I said, this is your material. This is the bone, looks like table sugar. That's what I said. And this is the piece of paper or the collagen membrane or the paper that I was referring to. What do we do next? Next, what we do is we take that piece of paper and we place it on the inside of the flap. Now, before I go further, let me describe this term as simply as I can so that, you know, when I refer to it again, you don't have to worry about it. It's called a flap. What is a flap? In simple terms, flap means, in the context of this lecture, when I reflect gums, I'll just call it a flap. So think about it this way. What do, if this is a tooth, let's say this is a tooth, okay? This is the crown, this is the root. The root is supposed to be completely covered with bone. So this is bone, okay? On top of bone, we have a layer of gum. This is gum now, okay? When I reflect the gum down, I have raised a flap. That's what a flap means, okay? So if I've reflected the gum down, I've raised a flap, what do I see? I see the bone. That's the basic concept. Now let's get back to this image. In this image, what I did was I took a knife. I won't call it a scalpel. Simple. I took a knife. I started going inside the tooth so that I can detach the attachment between the gum and the tooth. I went along the tooth here all the way here. What did I do? I was able to achieve a detachment of the overlying gum. I could remove it like this, and I was able to see where the bone was. Once I saw that, I took this piece of paper and I placed it next to the bone. Why? The idea is when I put my gum back, this piece of paper will prevent the gum cells from going inside the socket. Like I said, what's the benefit? It will give enough time for the bone on the inside of the socket to form bone rather than the gum from the outside entering the socket and forming gum. Okay. I'll spend more time on this in this part so that in the later cases, I will only be just saying flap or whatever, and you'll be able to understand. So what do I do next? I take this bone, which you're seeing here, and I pack it on the inside, fill this socket on the inside. Once I've done that, I will move this piece of paper or membrane and I will move it all around and I will tuck it on the inside of the lingual, meaning on the tongue side flap. What you're seeing on the buccal will be repeated on the lingual. So the final product will be like this. This is your socket. It has bone all around, and then a piece of paper coming from the buccal all the way wrapping all around lingual, and that piece of paper on the outside of that piece of paper will be your gum tissue. Okay, So far, so good. Hopefully, can you give me a thumbs up? Anybody? If it's okay. Thanks. Appreciate. Awesome. Let's move along. This is what you see. So this is the buccal side. This is the soft tissue. The next layer will be the membrane. Then on the inside of membrane will be bone everywhere, the native bone and the bone that we've added. Then we will cover the bone on the lingual side again with a membrane or piece of paper. And this is the lingual tissue side. Okay. We suture it up. These are simple sutures, nothing fancy. Suturing is just like, threading. Somebody saw me suturing and said, "Can you basically stitch my shoe?" Come on. I just suture it. I don't know how to do stuff. Okay. Now let's move on. This is what we do. So this is at the end of the procedure, and this is how it looks after 4, 5, 6 weeks. I don't remember the exact timeline, but this is this thing will transform into tissue. Looks beautiful. Membrane is dissolving, slowly going, but you can see it's still there. It protects this gum from going inside and gives enough time for the bone on the inside to form solid structure. So this is socket preservation. Now let's look at a case of socket preservation, which is slightly more common. Okay, let me tell you the story of this one, the shorter version. What you're looking at is a simple periapical radiograph. These teeth were endo or simply root canal treated. They were treated 15, 20 years ago. Patient had recurrent infection. So the idea was there was infection, root canal therapy was done, but somehow the infection reoccurred. So the root canal guy thought, you know what, I will reflect the gum, I'll clean the area, I'll do whatever needs to be done. And they attempted to remove a very small piece of root tip. It's a different procedure, but the idea is it helps in removal of infection. Okay. But in this case, they were not able to. So they sent the case to the root canal specialist, and they saw fracture or something. They said, you know what, Mo, it's not going to work. Remove these teeth, fill the area with. The problem was that this thing had been stayed actually for months on. And by the time the case was seen, it was seen by my colleague. And her plan was that she would just remove these teeth, pack some bone, just like the last case, and call it a day. I extracted the teeth, and then I took my instrument and I wanted to feel how the bone looks. So I had not reflected the flap at that stage. I just extracted, they were in bad shape. I took the teeth out, fine. But when I took my instrument and I went inside, trying to feel how the bone looks by feeling, I figured out there were big defects. The bone was missing on the buccal aspect. This is the area we're talking about. The bone was missing on this aspect in the vertical dimension, and the bone was also missing on the tongue or the lingual aspect. So if this was my socket, let's say, that means we are missing bone on one side and the other side. We had bone on this side adjacent to the tooth here. We had bone here. We had bone here, a little bit bone here, but generally the bone was missing on the buccal and the lingual aspect in this area. So instead of having a socket with 4 walls, we had this case. Bone on the sides, nothing on the buccal, nothing on the lingual aspect. So I reflected a flap, and this is what I see. In this case, this is the buccal flap. This is the lingual flap. I'll reflect it and you'll be able to see. And you start to see big voids or bone missing in this area. Bone is missing in this area as well. There's a little bit of bone here, but there was this defect on the buccal was continuous from here all the way here. Okay. This is the lingual aspect. So we can see the bone is missing again on the lingual. The picture doesn't do a good justice, but the bone was missing on the lingual aspect inferiorly as well. So it was a big bone defect. What did we do? We cleaned the area. We packed a ton of bone, which is again like table sugar, and we put the flaps back. And once we put the flap backs, we just called it a day. So this is how it was. And at the end of the procedure, This is how it looks. And in this image, you can see there is a ton of width. It looks really bulky because we added a ton of. One of my instructors used to say, Mo, when you do the GBR, bone grafting, make it look like a humorous mass. Make it look like such super bulky, because having extra bone is almost always not problematic. It's always the case where you don't have enough bone. So, and the other thing is when you pack, let's say, what I like to tell my patients is, I tell them, if I need a kilogram of bone, and they look at me, really, you need a kilo? I said, no, no, just giving you. Kilogram is easy to understand rather than ounces and grams or whatever. So if I need a kilogram of bone, I tend to add 2 or 3 kilograms, so that even if it's resorbed, some of it will be there for. So this is how it looks at the end of the surgery. Now let's see how it looks at the follow-up. This is after 4 to 5 weeks. Looks pretty good. And you can see in this area, compare it to this area, the native area. This area, in terms of this dimension, the horizontal dimension, doesn't look as bulky. This looks like there is a ton of bone in the area. And we put a flipper in there, looks beautiful, so that patient can function normally, look normally for the next 5-6 months when the bone gets enough. We can see even in this area, there is a ton of, looks beautiful. So this is another procedure. Now, this is another case. It's a very interesting case. This case has 2-3 problems going on, but for the sake of this presentation, I will only touch upon one. Okay. Now, if you look at this image, the image doesn't look that bad. What we will focus on is tooth number 2-1. So if I'm the patient, I've opened my mouth, you're looking at my upper left central incisor, okay? This is the area. Doesn't look that bad. Yes, there is space. This space is because there was a history of periodontal disease. Past patient didn't take care of the area properly, whatever the reason was, in the space occurred because of. But it doesn't look that bad. There is not much gum recession, doesn't look that bad. But let's look at the CT scan. What do you see? Let me explain. This is an image taken from CBCT. For the sake of this discussion, again, I'll just call it a CT scan. Okay, makes it easy. You're looking at this area, my upper front 4-5 feet, this area. What you're focusing here, where the arrow is, this is tooth number 2-1. Okay, this is the central incisor, the upper left center. All the soft tissue has been stripped away, meaning muscles, mucosa, gingiva, everything is gone. What you're seeing right now, this is all bone. This is all bone, okay? All you're looking at is the hard structure. So what we have is the bone. This is the crown, a crown and a crown, and then we have the roots. So here we can see the root, we can see the root. Again, the root, this is the crown. These are the lower anterior teeth, okay? Now, if you look at the level of the buccal bone, we can see that the bone, this is the aspect, this is the buccal bone. This is tooth number 2-2. I am going along the buccal bone. This is, you can see, this is where the buccal bone, whereas it's almost here for the adjacent tooth. That means this is such a big vertical defect. Can you see that? This is all the bone which is missing. But the palatal looks much worse. And one more thing, bone grafting on the palatal aspect is way more challenging than the buccal aspect. And bone grafting in vertical dimension is more unpredictable dimension. So this is a really problem case. Let's look at the palatal aspect. Now let's orient ourselves. How are you looking at this image? If I was the patient, I would have opened my mouth like this, and you would be standing here, you would be looking at this way, meaning my upper maxillary teeth would be upside down because my head would be in this position. You get the orientation. In terms of orientation, give me a thumbs up if you can get the orientation. Okay. Any problem? Any student so far? No problem? You can give me a thumbs up. Come on. Come on. Thanks. Appreciate. So now, once you've got the idea of the orientation, let's look at this image. Again, same image. I've just moved it around. Okay. You're looking at the palate aspect. We are going from tooth number, this is tooth number 2, going all the way to 2, 1. Sorry, my bad, I apologize. This is tooth number 1, 2, going from 1, 2, 1, 1, and this is where the bone is supposed to be. And you see, this is where the bone drops down. Like it's a really big vertical defect. I mean, even on tooth number 2, 2, it's messed up. It's bad. So what do? We decide to fix the problem. Oh, one more thing. Look at this image. So this is a cross section. What does this image show? Let me explain. In terms of orientation, if I'm the patient, I'm looking this way, and you're looking at me from the side, okay? What do you see? In CT scan, CBCT technically, you focus, you can see the hard structures nicely. Soft tissues, not so much. So this thing, let's see, this thing is the upper lip and all the soft tissues around. So in terms of orientation, patient would be looking forward. This is the upper lip and the muscles in the area. This is the incisor we are focusing on. This is the buccal or the lip side bone on the incisor. This is the root. And then you can see there is almost zero bone. This is all the bone above. So close to nose, this is where the bone is, okay? On the palatal aspect, you don't see any. So that tells me that we have almost, or whatever bone is, it's super thin to the point that it's not even visible properly in the scan, okay? How do we approach this problem? Most important thing, take a sip of coffee. I am a coffee junkie. Okay, so this is how things look clinically. What I do is I take my knife, aka scalpel. I go in the area like this, like this, like this. Why do I go in such a wide area? Told you this particular case had other issues going on. I'll not talk about it, but I had to clean a bigger area. So, and when I say clean, I do the exact same thing like you folks will be doing, which is just using a scalp, using a Cavitron or Curette and just cleaning the area. And in my opinion, if I know a lot of periodontists would hate that when I say, but in my opinion, hygienists generally do a much better job than most periodontists when it comes to cleaning. And a lot of my colleagues will not like it, but I'll say that because I believe in it. And why do I say that? A similar example would be if you go to a medical facility and they say, okay, we want to give you an injection or you need an injection. If somebody was to give me the choice, would you want to be injected by a doctor or by a nurse? I would always pick the nurse. Why? They do it on a daily basis. They do it thousands and thousands and thousands of times in their professional career versus a doctor. They don't do it that often. So what does that mean? If you get pricked by a doctor, chances are you'll be like, that hurts. So same thing, the hygienists tend to do a much better job than periodontists. Okay, so what do? I take my knife, I go in there and I go like this, like this, like this, and I reflect the gum, which means I have raised the flap. Once I reflect the gum, what do I expect to see? Some bones, some roots, and some bad tissue. When I say bad tissue, it means granulation tissue, necrotic tissue, really bad tissue. And that bad tissue signifies that this area, and I'll show you where the bad tissue is, used to be bone, but because of infection or whatever reason, that thing has transformed into mushy bad tissue. And once you remove it, then you're able to see the devoid, the void, or the defect in bone. Okay. So, excuse me, what I've done is I have raised my flap. So what you're looking at right now, this is the bone, or that's how it looks. Looks like bone, but this is the bad tissue. This is what I look. Okay. This is good bone. This is the crown. This is the crown. And you can see part of root canal. Let's see what happens next. This is the palatal aspect. So once I raise the flap, meaning I've reflected the gum on the palatal, patient is, if I'm the patient, I'm lying like this, and you're looking at me from this view, okay? This is what you see. This is tooth number 1, this is tooth number 2, 1. And you can see already there is more root exposure, meaning more bone loss in that area. This is all the palatal, okay? Next what I'll do is I'll extract the tooth, because tooth is grade 3 mobile, super loose. As patient speaks, the tooth is like, they want to take it out, okay? We've taken it out. Now, this is key. Keep an eye as I move my cursor. This is the top position or the occlusal aspect of the bone on the adjacent. This is where the bone is, and it starts to go down, here, all the way down, and starts to come back slightly upward. It's more clearly evident if you look at on the palatal aspect. Again, the bone at the highest point is here, drops down all the way, really deep palatal. Hair starts to creep up. And if you want to get a better idea, look at this, how far down we are when we compare this point all the way up. This is my flap. Get the idea? It's a lot of vertical defect. It's a big vertical defect. The other problem is, this is my horizontal dimension. It's not enough. If I want to place a 4mm implant, and I'll use this time to explain another concept as well. If I want to place a 4mm implant, what does a 4mm implant means? Means the diameter is 4mm. So let's say this diameter, this circle is 4mm at the top. If I want to place an implant which has a diameter of 4mm, there are certain principles I need to respect. Number one is, if this is my implant, it should have at least 1.5, ideally 2 or 2+ millimeters of bone on the buccal aspect. So let's say this is my implant, okay? This is how it will go inside the bone. So in this dimension, this is the buccal dimension, let's pretend, I need at least 1.52 millimeters of bone in this dimension, okay? On the lingual or palatal dimension, I need a millimeter of bone. So, which basically means if you have a 4mm diameter, you need 2mm on the front, you need 1mm in the back, you need at least 7mm of in horizontal. Get the idea? Good. Let's move on. Thank you. This, folks, is not 7mm. So, in my head, I'm thinking, okay, I'm dealing with a situation where there is a vertical defect and there is a horizontal defect. So I need to add a ton of bone in the area to make sure that I end up with a tumorous bone-like structure so I can put my implant there down the road. Okay? How do I do it? And once I've cleaned the area, this is another good picture. You can see, look at the vertical defect here. This is the most apical end, and this is how big the vertical defect is. It's like huge. And vertical defect regeneration, very difficult. So this is the problem. Same thing on the buccal, way down. And in terms of horizontal, once I've removed the necrotic tissue, you can see the area is very minimal. Bone is not optimal. So what do? We add our table sugar here. This is how it was. And this is where I've already started adding. One thing I forgot actually, so I'll go back and I'll explain. Now, what was my approach? I said I like to achieve two things. One, I want to localize the bone. Number two, I don't want the gum cells to go inside the growing bone. So what I did in this case, which I don't have image for, I placed a membrane, aka a piece of paper, extending from here all the way on the palatal aspect, from here all the way here, and I fixed it somehow magically. I just made sure that it stays there, it doesn't. Okay. Then what I did was I did the same thing. So I put another piece of paper extending from here on the buccal here. So what I've done is I've created a paper wall on one side, paper wall on the other side. I've filled it up with the table sugar. And then what I will do is, this is my palatal, let's say, okay? So there is a paper wall on the palatal, there is a paper wall on the buccal, the space in between gets filled with my sugar, and then I will wrap my buccal paper wall here, and then I will close it off. Make sense? That's the idea. If I want to do an extra step, if I want to really be like, an awesome dude, what I'll do is I'll go an extra mile. In this case, an extra paper. So what do? This is my palatal. This is my buccal. I cover it up like this, but to make sure that, there is no way of gum growing in, I put an extra layer of paper further on the buccal, and you'll see it in the image. The idea is we want to limit all the gum cells from coming in. So in this image, you're looking at from this view. So this area is the buccal area. This is the remaining part of the palatal flap. In this area, I've already placed my piece of paper. My paper wall has already been there, established already there, not being shown here. This is my sugar or bone. And if you look this image from another aspect, you can see, now this is the buccal aspect. This is patient's lip. Okay, this is the lip. This is the buccal aspect of the teeth, buccal aspect of teeth. This is the palatal wall. And on the inside of this tissue, there is already my piece of paper. This is the bone that I've added, and this is the piece of paper or membrane on the. And what I'll do is I will pull this over the bone, wrapping it into the palatal aspect. And you'll be able to see that in the next image. This is how it was. This is how it looks. And in this image, you can see that my membrane is extending from here all the way, wrapping going. And somehow I'll just magically fix it so that, this doesn't move. Then what do I do next? If I want to go the extra mile or the extra membrane in this case, I just put another piece of membrane on top of it to make sure it looks awesome. And then what I do, I just close it off. And technically speaking, I absolutely loved it because it's not easy to close things properly at the time of extraction. So this looks pretty cool. This was a case we did quite recently, so I'm hoping that we get a good result. I was supposed to see the patient actually for the post-op, but because of the corona thing, I could only give him a call, talk to the dentist. He's doing good, but hopefully we'll get a good result in 6 months' time when we take the scan. Now let's move to the next topic, which is bone grafting. What is bone grafting? What we do is in cases where it's an edentulous site, tooth is not present. And remember my example, if this is my implant, I want it to be surrounded with bone on all sides. I don't want this to be this, where you have bone on one side, looks amazing, looks bad. I don't want that, okay? So in a case where tooth is missing, we try and build the area and create enough bone so our implant is surrounded by bone all sides. So this is the case. Tooth is missing, bone is deficient. We just pack some bone, then we call it a day. Where do we do it if there is just not enough space, or there is not? Typically the limitation is, remember I said we want 2 millimeters, 1.5 to 2 millimeters or more bone buccal aspect of. We also do it sometimes at the time of implant placement. I think I have a case, we'll talk about it. This is a very simple case, very simple, good, easy to understand. This is a case, I'm the patient, I'll open up my mouth like this. You're looking at me from this view. I am missing tooth number 4, which can be seen here. What I've done is I've reflected a flap. In simple terms, I've reflected the gum. So going from tooth number 5 like this up to tooth number 2, I think in this case, we have just reflected the gum. What am I looking at? I'm looking at bone. This is the bone. If you watch carefully, there is a concavity on the buccal aspect of tooth number 2. So if I was to place an implant right there and then, my implant would be exposed, the buccal aspect of the implant would be exposed if it was to go in. Now, this case was done in my first or second year of residency. And I wanted to place the implant and do bone graft, but my instructors, rightfully so, they figured out I'm being a cowboy, not good enough. They said, no, just do the bone graft, go back and place the implant. And I was like, okay, I'll do it that. Okay. So back in the day, that's what I used to do. So what do we do next? This is the case. This is a better picture showing the concavity properly on the buccal aspect of the tooth 4. And we'll use some table sugar. This is my favorite, my table sugar. And then we'll protect this area with a piece of paper. This is the table sugar. This is the piece of paper lying on top of it. And then we will close this area and suture it. And this is how it looks at the time of suturing. The key thing is, like I said, in the ideal world, we want 1.5 or 2 millimeters of bone buccal aspect of implant. When we go back at the time of implant placement, let's see if we've got it. Turns out it looks pretty good. So this is how my final implant would look like. This is how it will go in the bone. And if you watch, this will be the buccal aspect of the implant. So there's a ton of bone from here all the way here. So we've got, I don't know, 4 or 5 millimeters aspect. It's amazing. So that's how we do it. This is another case. This is a case where a bridge is failing. So going from tooth number 2-1 to 1-3. Long story short, the bridge was failing. The plan was we would remove the bridge and we would also extract this tooth, which is 2-1. Okay. So we removed the bridge, extracted the tooth, let the area, patient was given a flipper, let the area heal, and then we decided to do bone graft. In this case, patient was missing tooth number 4-7. So what you're looking at is a case where tooth has already been extracted, tooth number 2-1, and the patient was wearing a flipper or a partial denture or whatever you want to call it. Patient comes back 5-6 weeks later after extraction. Why do we do it? So in some cases, remember I said in the previous case where I said there was a big defect on the palatal and buccal, and I said it's amazing, I'm really happy that we were able to close things. And I said it's challenging, it's difficult to close an extraction site. Why? Because we don't have enough soft tissue. If you think about it, if this is my extraction site, my gum is here and my gum is here. This 10-12 millimeter of space doesn't have any soft tissue. So it's difficult to move gum from all the way to the other side and close it off. So sometimes, in some cases, what we do is we do the extraction, let it be as it is for some time, then we go back 6 weeks later and do the graft. What's the benefit? During those 6 weeks, the soft tissue grows and closes the area, so we have enough soft tissue to play around with during the bone graft. So just on the side. Now let's get back to it. So tooth number 2-1 has been extracted. You can see that the gums have completely closed the area. What do? We take a scalpel or knife. We go in like this, then we go a straight incision like this, again like this. And what do? We raise the flap, meaning we reflect all this tissue away. And what do we see? We see a big effect. This is what you see. This is the extraction area of tooth number 2-1. Okay. This is all the bone loss in the area. This is the palatal side. This is all the buccal side. This is the nasal spine, meaning, yeah, it looks a lot of gory stuff. I apologize, but this is what you do. Now, patient is missing tooth number 4-7. What do? You go back in that area. You take a little bit of bone from this area and you put it here. Okay. So we go to the lower right side, we take the bone from there, and we put that bone in the recipient area. These are screws. The idea is same. Remember I was saying magically keep the piece of paper fixed. So one way of doing that is to use screws. You just drill so that the bone or whatever you want to fix doesn't move. Okay. So these are some screws fixing that piece of bone into the recipient area. So this bone, the bone that we've taken from here, doesn't. Then what I did is then add some bone in that area. Remaining, you can take some bone, add in this area, and cover all this with a piece of paper. This is what you're looking at. All the empty space is then filled up with bone, covered with a piece of paper, and then we close the site. This is how it looks before closure. This is how it looks at the time of closure. So now that it's completely closed, patient comes back 3 weeks later, it's still pretty much good. It's completely closed, looks good. Then at the time of implant placement, this is how we can remove the screws and we can place the implant. This is at the time of placement. So this is my drill before placing final implants. And once again, this is the palatal aspect. This is the buccal aspect. You can see there is a good amount of bone on the buccal aspect here, more than 2 millimeters on the aspect. Same thing, more than 2 millimeters on the aspect. What is this thing? This is a guide. So let's say I want to place implant. I want to make sure that my implant is placed exactly where I would want it to be. How do I make sure that I place it properly? One way, especially during residency, what we would do is we would take the impression, send it to the lab, or whatever we did. They would give us artificial teeth, which we would put in the missing area and use those as guide for drilling and making sure the implants were coming out from exactly where I would want them. And one test was once I had done my initial drilling and everything, before placing the implant, I would put my guide back in there to make sure that my drills or my things or pins are coming out from the exact hole where they are in the guide. So it fits. So it's just a check to make sure that implants are done properly. So this is what you see. Now, this is another interesting case where bone will be added at the time of implant placement. So how do we do it? This is a case patient is missing tooth number 1-1. So what you're looking at is the buccal aspect. This is the buccal. This is 1-1, which is missing. What do we do? Simple. First thing, like always, reflective flap, meaning reflect the gum, incising this area. Once I've reflected it, this is how my implant will go. This is a drill. This is a piece, a pin, or a drill, whatever you want to call it, goes in there, coming out exactly where I would want it to be, makes me happy, and then you can see it on the x-ray, looks completely fine. You want to make sure on the x-ray that you're not hitting the roots of the adjacent. That's one important aspect. There are other as well, but we'll just talk about it for now. Okay, the implant is already in. What I did was I used an instrument to remove some native bone, patient's own bone, from the side, and I started packing it up on the implant. So this bone was taken from sides, patient's own bone, and I was packing it up on the buccal aspect of it. Okay. Then remember I said my instructor says add a ton of bone to the point it looks like a tumorous mass. Before I do that, I want to make sure that the gums are so loose that I can move them from the buccal all the way to the palate so that I can really loosen things up and wrap them all around the palatal aspect. So this is just a test to make sure that my gums on the buccal aspect are super loose. This is the bone that I've added from the outside, table sugar bone. This is an occlusal shot. So if you were to look at things from this view, this is how much bone is added. I don't know, it's 12 millimeters maybe. I don't know, it's way too much than needed. But the idea is you want to make sure that you have more versus not enough bone. And this is the piece of membrane which is being added and it was being positioned. And this is at the time of closure. And this is the x-ray. Looks pretty good, looks between the roots. This is all the extra bone. Now, this is another interesting case. This is vertical bone grafting. This is the case as I received it. Now, what does this case show? Now, short story is patient had root canal treatment at tooth number 3141, which was done, I think, 20, 30 years ago. Developed infection. Because of the infection, patient was advised to have 3141 extracted. And he said, you know what, I'll get it extracted. He was probably a lazy bum like myself and never had the teeth extracted because the root canal specialist also advised that, you know, they were bad. So the general dentist extracted the teeth. He extracted the teeth and then sent the patient. When the patient came back, I took the scan and I figured out there was a lot. When I reflected the flap, this is what I see. Now, this is the tooth number 4-2. This is tooth number 3-2. If you look at the bone level on the buccal, this is how the bone looks. And it starts to drop down about 10 millimeters vertically in this area. Then it goes back up. This is the buccal. Same thing is happening on the lingual. On the lingual, it goes like this. This is part of the flap, comes in here, drops down, then it starts to go back. So what we have is a situation where we have a vertical defect of about 8 to 10 millimeters on the buccal aspect and the lingual aspect. So it's difficult to treat. What do we do? Like always, what we do is we create a wall made out of paper on one aspect, the buccal, wall on the lingual, place a ton of bone in the area. Then we move the buccal wall of paper, wrap it on the lingual, and then we move the soft tissue so that they are closed on top of it. So this is what we did. And once we had done that, we sent the patient back. Patient comes back after 3 to 4 weeks. And what do you get? This is another image showing the same thing. We have a big defect and looks quite messed up. So we fixed that. We send the patient. This is what we had. And this is what we have now. Looks beautiful. Looks like, just looking at this tells me, okay, you know what? We should have a good result. We should have enough bone, enough thickness to place an implant. But let's see how it looks at the time of implant placement. This is what we had. And remember, it was a vertical. This was the healing. And this is what we have at the. You can see this is all bone. This is all bone at the time. And there was no bone in. This is how it looks. We take an X-ray. Looks pretty good. And on the X-ray, if you carefully watch, this is all the bone from the outside. Like it's a lot of vertical. Turned out quite well. And this is how it looks when the area was sutured up, patient was sent back. I actually requested my colleague, he restored these and they've been in there for about 1.5 to 2 years now. I asked him, but he was also a lazy bum like myself. And I'm yet to receive the final images. I remember I saw it looked pretty good, but I wanted to take a good quality picture. So hopefully I'll get it for my next lecture. Now, this is immediate implants. This is another nice case. This case came to our office like this. It was close to Christmas, 1 or 2 days before Christmas. This is dad of a dentist. So I was super happy given the fact that a dentist who's been working for quite some time, 20, 30 years or whatever, she wanted me to fix this problem for her dad, which tells me that, okay, makes me feel good that, okay, I must be doing okayish perio or surgeries that she has enough confidence in me to get into it and try to fix. So the case was the dad had the FTP, or simply put, a bridge in that area. Just a couple of days before the Christmas, the bridge broke off and they made a temporary partial denture or whatever. And they sent the case to us asking, please fix it ASAP. Okay, so what do? We extract the roots, the remaining roots here. This is 1, 2, 1, 1 is missing. This is 2, 1. So we extract the root here, we extract the root here, and we place immediate. Remember, I was said immediate means you extract and you put immediately in place. So we extract this root, put an implant here, add a lot of bone on the buccal aspect, close it off. This is what we had. I've already extracted the roots. I've done my initial drilling, and this is what I see. So this is 2, 1. This is 1, 2. This tells me I will have enough space where I can pack it up with bone on the buccal. So I'll end up in a situation where I will have 2 millimeters, 3 millimeters, if not more, of bone on the buccal aspect, which I want. The X-rays makes me happy. that my pin or my direction of drilling is parallel to the adjacent tooth, which I want in the ideal. On the other side, at 2-1, same situation, I'm parallel to the adjacent root, makes me happy. And I'm also parallel when it comes to the implants between themselves, which makes me happy. This is just before adding the implants in, putting the implants in. This is the final pin or whatever direction I want to see. Looks pretty good. This is the buccal shot. So now the patient is lying in the chair, you're looking at from behind. So this is the buccal aspect. So this is what you see. Looks pretty cool. The occlusal shot, what I've done is the implants are already in, and now this is what the implants look like. I will pack this area with bone. I've already added bone all around the area. Now I want to protect that bone, so I'll put my piece of paper in the area. This piece of paper has already been placed now, and I've put a couple of stitches. How does the patient look when he leaves the office? This is how he looks. So looks pretty good. He's pretty happy. Now let's look at something more fun. It's called indirect sinus lift. What's an indirect sinus lift? Indirect sinus lift is a case if this is my sinus, I want to place an implant like this. If I place an implant like this, the upper part of the implant will be in air, this part. I don't want that. I want the implant to be surrounded by bone. What do? I somehow lift the floor of my sinus so that when I place the implant, the upper part is also surrounded by bone. So lifting of the floor of the sinus is called indirect sinus lift. How do we do it? I'll explain that. The key thing is there has to be a certain distance from the bone which is present here to the floor of the sinus. So there has to be a certain vertical height present if you want to achieve this thing successfully and predictably. Let's look at a picture to get a bit better understanding. Let's pretend I'm the patient. You're looking at me from my right side, or from my front, and you're looking at things in this view. We are focusing at tooth number 16, let's say. What do? You're the surgeon, you come on and you start drilling in this area straight up to the sinus. If you look at this image, this is the floor of the sinus. This is where the floor, this would be the lateral wall. This is where the cheek would be. So you remove the cheek, you remove the gum. This is the gum in this image. And then you see this bone. Once you start seeing this bone, you start drilling at the 1/6 straight up towards the sinus. When you're about a millimeter below the floor of the sinus, or in other words, when you're about a millimeter before you would enter the sinus or the air, you stop. So you drill till you are about a millimeter short of the sinus. Once that's done, you remove your drill, you take a blunt object, you place that object in the path of where you've drilled. Then you take another instrument and you gently knock that blunt object. Tuck, 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 tuck. What you're trying to achieve is, so this is my blunt object. I'm inserting it in the path where I've already drilled. Now it's very close to the floor of the sinus. I take a hammer, exactly, but we'll call it a hammer, and I'm doing tuck, 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 tuck. What does it do? It creates a small fracture in the floor of the sinus. And then we call it a flexible green stick fracture. Then when my final implant will go in there, it will be able to push that small fracture upward. So what will happen is, if you watch the first image, this is where the skin, so sinus has a skin on the inside. We call it a Schneiderian membrane. I'll just call it skin for now. What we want to do, and that skin is attached to the floor of the sinus. What we want to do is push this thing upward. So if you keep an eye on this thing here and compare it to the final image, you see it's dome shaped, it's moved up. This is indirect sinus lift. Indirectly, we've moved the floor upward at the time of implant placement. Basic idea, did you get the basic idea? Good. Now let's look at the case. This is a case where patient was referred. Patient had a failing 1.4 and 1.6. It's a periapical radiograph. You're looking at things from this view. There is some funky business going on at 1.4 and 1.6. Both teeth were super loose, grade 3, mobile, and the plan was that we would extract this tooth and this tooth, and at the time of extraction, we would add a ton of bone. And what we would do is once the bone has healed up properly 6 months, 7 months down the road, we would open the area, place implants. Keep an eye on this area. This is where the sinus is. Looks pretty close, okay? Now, I don't have pictures, but the idea was teeth are already extracted. Bone was added. 6 months, I've pressed the fast forward button. Zook! 6 months have passed. Patient comes back. I take a CT scan, aka CBCT, and this is what you see. So I want to plan my implants on the final scan. How will I place my implant? So this is an image taken from the CT scan showing this is my 1.4 implant will go. This is where my 1.6 implant will go. Okay, so this is a planning software. You can play around like a video game. And before doing the surgery, you get an idea, you take your measurements. So this is my planning. I start drilling the area. This is my tooth number. In this case, this is tooth number 1.3. My drill close to 1.4 tells me my implant will be parallel to the root, which is what I want. This is tooth number 1.7. So this is where the implant 1.6 will go. So what I wanted to check was how far short of the sinus I am, and I wanted to make sure my implants are parallel as well. This is the X-ray showing the final implants. This is the implant at 1.4. This is the implant at 1.6. And if you watch carefully, you can see this is where the sinus is. So this part of the implant is inside and I use the technique of indirect sinus lift. I'll show it in another case, but that's the basic idea. And this is how it looks from the clinical standpoint. I've reflected the flaps. This is the buccal flap, meaning the buccal gums. This is the palatal aspect. This is the implant at 1.4. This is the implant at 1.6. And remember, like I said, there is a lot of bone on the buccal aspect, more than 2 millimeters on the buccal aspect. Here, there is enough bone again on the buccal aspect. So it looks pretty good. But let's make it even more simpler. Let's look at this X-ray. This is an X-ray. If I'm the patient, you're looking at my 2.6, 2.7 area. It's a periapical radiograph. This is my 2.6. This is my sinus. I want to place an implant. This is where my implant would go. Okay. This distance from the crest, where the implant will start from here. Oops, my cursor. The distance from here all the way to the floor of the sinus is 10 millimeters. That's what it says. Distance from the crest to the sinus floor. This distance. This is bone. If you watch carefully, you can, see a shadow. This is soft tissue. The X-rays don't typically show good soft tissue. So this is soft tissue. This is the osseous or bony structure you're looking at. This is the sinus area, the distance from the floor of the sinus, and this is all the air inside the sinus. So the distance from the floor of the sinus to the crest of my bone is about 10 millimeters. This is my drill. So I've done my drilling. I've put my instrument in there. And like I said, it's almost a millimeter short of the floor of the sinus. At this stage, I will take my hammer and I will knock it to make sure that I get my green stick fracture. And when my implant goes in, it pushes this floor upward. So if you watch here, my implant is here, and this is the floor of the sinus, which has been pushed. This is how it's done. From clinical standpoint, this is how my implant drilling process looks. And this is my final image after 4-6 weeks, and looks pretty good. This is where my final crown will come. Okay. Now let's go to something more fun, which I absolutely love, which is direct sinus lift. Now, remember I was talking about it. Let's go back to the image, this image. When we have a distance of 5 millimeters, in this case, we had 10 millimeters distance. If we have up to 5 millimeters, we can use this technique. But if we don't have 5 millimeters, if we have 3, 2, 1, 4 millimeters, we use a different technique. What we do is, in that case, instead of going like this, we go from the side. It's called direct sinus lift. Why do we say direct versus indirect? Simple. When we go from this direction, we start from the alveolar crest or the jawbone, and we use the jawbone to indirectly reach the sinus. Okay. When we come from this side, we go directly to the sinus. That's why if we don't have enough bone, we have less than 5 millimeters of bone, we need a bigger procedure, we go direct. That's why it's called a direct sinus lift. Let's have a look at that. How do we do it? I'll use pictures to make it simple. This is an image. Again, I am the patient. You're looking at me from the front. If somehow magically you could give an incision here, don't do it, just saying, okay? And you could open things up, put my face down, please don't do it. But if you put it down and get a direct visual, this is what you will see. And this would be my right sinus, okay? So you're looking at me from the front, and somehow you use a saw or whatever to section give a section like a coronal incision in this area, put things down. This is what you see from front on. Now, let me explain. This thing that you're seeing, the pink thing, would be the gum on this side. So let's pretend, let's visualize, let's imagine for a second, all my cheek muscles, everything is removed. All that is left is the bone and gum covering. In other words, if I was to retract my upper lip or cheek, you'd be able to visualize things from this angle. So this is my gum. If I raise a flap and reflect the gum this way, you will see my bone, this bone. And that is being shown by this structure. So this is the bone you will see. So let's pretend we remove my muscle, cheek, gum, everything. What do you see? And you're looking at from this view. This is what you will see. This is the bone. Okay, this is the maxillary bone, and this is what you will see. Now, on the inside, we have the sinus. Why we call it maxillary sinus? It's inside maxilla, which is this bone. So we call it maxillary sinus. Now, what happens is, like I said, there is a skin on the inside of sinus. Where is that skin? We call it Schneiderian membrane or membrane, I'll just call it skin. This is the skin. It's here on this image, this skin. Okay. Now let's imagine I want to place an implant at tooth number 16. This is where my implant wants to go. But this height, this is the height I was talking about. This is, let's say, 3 millimeters. If this height is 3 millimeters, based on what we discussed, I cannot do indirect sinus lift. I cannot place a 10 millimeter implant. Why? If I was to place a 10 or 8 millimeter implant here, and this bony height is 3 millimeters, then the rest of the implant, 5, 6, 7 millimeters, would be in air. It will not be surrounded by bone. It will be a weak structure. Make sense? So what I do is, I cannot place an implant with indirect sinus lift. What I would do is somehow magically, I will move this piece of membrane, and this side is the lateral side. So you're looking at, this is the lateral, this is where the nose is. This is where the nose is. This is where the ear or the lateral side is. So what I want to do is move this pink membrane towards the nose. If I can move this membrane towards the nose, it will leave a void in that area. And I can fill that void with bone. What will that do? If I can fill that, if I move this pink thing towards the nose, it leaves a big void here. I fill the void with bone, I have suddenly created 7, 8, 9 millimeters of bone. And instead of 3 millimeters, now I have 10, 12 millimeters of bone. Now let's look at it from clinical standpoint. This is a case. Tooth number 16 is what you're looking at. The tooth was failing, it was extracted, and then the case was referred to us. Let's look at the area. This is how it looks clinically. This is how the radiograph or the X-ray looks. This is how it was after the extraction. Another X-ray was taken or radiograph, and this is how it looks. Now, if you look at this one, this is how the bone is. This is the sinus floor, and the bone has been lost up to here. So we have maybe millimeter, maybe 1.5 millimeter of vertical height before we go inside the sinus. This is how it looks. I took a scan, and same thing. This image is now from the CBCT or CT scan. But it doesn't tell me exactly how things will be if I wanted to place an implant. So I'll use another section. What I will do is, I want to look at it from another view. What I'll do is I will pluck this image out. Let's say I'm talking about the section between these blue lines. Let's say I want to take a piece out. If this was a cake, let's imagine I want to give a cut of the front and the back and take a slice out so I can look at it from this view, this view, this view, okay? This is what I'll do in the next slide. This is what it was, and this is how it looks. Now what I've done is I've taken a section out of here and I'm looking at things. This is the buccal aspect. This is the palatal aspect. The darker gray area is the soft tissue. So we have gum on the roof of the mouth or the palate. This is the gum from the roof of the mouth, soft tissue on the roof of the mouth area. And the soft tissue on the cheek, patient may have fatty cheeks like me. So this is what you're looking at. And this is the buccal aspect, okay? This is the lateral wall. This is the lateral wall or the side wall. If I'm the patient, this is my ear. This is the bony wall that I'm pointing. This would be my lateral wall, okay? Then coming down, this is the buccal aspect. If I wanted to place an implant here, my implant doesn't have any bone in this area. And the vertical height present right now is maybe a millimeter. So what do I want to do? What I will do is I will reflect all this soft tissue so I can access this hard structure, the bone. Then I will create a small window or opening inside this area. So what I'll do is I'll remove even bone here. Once I remove the bone in this area, I will be able to access that skin or membrane inside the sinus. This is all the sinus cavity area, okay? Not all, but you get the idea. So this is my sinus. What I will do is I remove the bone here. I will reach the skin, not really visible here. Remember, CT scan doesn't show good soft structures. I will push the skin in this direction, this direction, this direction, this direction. So I'll move all the skin from here all the way here. What will this do? It will create a void in that area, and I'll be able to fill it up with bone. Now let's look at this image. What I'll do is I'll use another example. I'll use another case to explain how the sinus surgery is done. And then I will come back to this particular case and show you what we were able to achieve. So let's look at another case just to understand the sinus level. What you're looking at is a case where patient doesn't have any tooth remaining. You're looking at area 26, 25, 24, this area. What I've done is I've reflected their cheek up. Next, I gave an incision, and through that incision, I was able to reflect all the gums up. Now, all the gums or the flap has been raised. What do you see? What you see is the bone. This is all maxilla. This is their alveolar bone. And then I remove this bone. All this bone has been removed in the form of a window. And what you see is the skin or the membrane on the inside. This is the skin which is on the inside of the sinus. What I want to do next is move that skin inward and upward, in and up. When I move it in and up, it will leave a void, and I will fill that void with bone. So this is how it is. I've started to release the skin, loosen the skin so that it can go in and up, in and up. How does it look during the surgery? This is what you will see. So now what I want you is to focus on this spot. This is patient's bone. This is the skin on the inside of the sinus. I've reached this stage and I would try and release it, But before I release, this is how it looks. At this stage, I would be asking the patient to please breathe. I would ask the patient to breathe. There is almost zero movement in the membrane.
Yeah, just a couple of more.
Just doesn't move. So this is the stage where there is zero movement. Next, I use this instrument to release the skin gently. I don't want it to be perforated or ruptured. It can lead to bad consequences. So I gently work around. Now, before it's thoroughly released, it's partly released. How does it look? Keep an eye on this structure.
Again, breathe through
So I'm
nose,
asking the
heavy
patient,
breathing,
and you can see there is a little
and
bit of
breathe
movement.
through.
You can see
Kindly breathe through nose.
a little bit of
Beautiful,
movement.
thank you.
Okay.
Yeah.
Now I've released it more, and keep an eye on this spot. How does it look before we add? Keep an eye. This is how it looks. Keep an eye on this spot.
And breathe.
Boom.
Beautiful. Once more. Breathe. Beautiful. Thank you.
This is the void. This is the void what I'm looking for. And now let's look at it again. I love this part.
And breathe.
This is the void. You see the void in the area?
Breathe. Beautiful.
Nice. Makes me happy. And now I'm in business. What I'll do is I'll just pack bone in the area. So this is what we are at. We release. Since this thing goes in, this is where we are. And then we pack it with table sugar, tons of table sugar. And then we want to localize it. We want to protect it. So we put the piece of paper. This is just the piece of paper covering it. And then when I was still suturing up, my colleague took this picture. I'm suturing the area. This is just some saline. You can think of it like water that's being thrown in the area, keeps the tissues moist, keeps them nice. 3 weeks later, patient comes back, looks pretty good, looks pretty cool. So the question is, the important question is, the $1 million question is, what were we able to achieve? What did we end up with? This is the situation, and this is the situation. This is all new bone. It's a ton of bone. But the important question is, we only had about a millimeter here. How does it look after healing? This is how it looks. Looks amazing. This is what you have. It's a 10 millimeter implant. I can put a 15 millimeter implant, no problem. This is all new bone. The other thing is, this is all new bone as well. So if you watch, we've got some vertical bone height back in this area as well. Looks beautiful. This is another case, slightly more challenging case. So patient comes back. In this case, let's also look at the X-ray on the side. This image is taken from the CBCT or CT scan, as I was saying. This is tooth number 1-3. This is 1-4. Failing, has a vertical root fracture. And the plan was we would extract this tooth. Patient has a Pontic or missing 1-5-1-6. So the plan of action is we would extract this. We will do a sinus lift in this area. This is something which makes things very challenging. It's a septa. I'll not go into detail right now. But this peak, it's not fun. It will complicate things. or potentially can. So we have to keep in mind when we are doing the procedure. But the plan of action is, my approach will be that I will do a direct sinus lift in this area, so I can have some bone in this area. I will end up placing an implant here and an implant here. So the goal will be, I will place an implant after healing at 1.4 and 1.6 and put a bridge in that area. This image was taken midway through the procedure. What are you looking at? So this is the buccal flap. If I'm the patient, you're looking at things from this view. I've reflected things up. So this is tooth number 1.3. This is the 1.4. The 1.4, you can even see two roots of, not exactly, you can see the fracture line here on the 1.4. So what I started doing was, I started creating my window or my sinus lift. I started with my sinus lift in the area of 1.6. Now, if you really look closely, so I already discussed in my X-ray view of scan that there is septa or things that will complicate. The other thing which is not being shown, if you watch carefully in that scan, is shown here. This is an artery. If you watch this closely, you don't want to mess around with this artery. So what I did was, I created a window so that I'm above the artery and I'm beneath the artery, and I work around so that the artery is completely, I don't cut the artery, because otherwise it can bleed profusely. So from a technical standpoint, it makes it even more difficult now. But what I did was, I created my window just like in the last case, and I was ready. Then I extracted this tooth and I added a lot of bone in this area, a lot of bone in the sinus, and then we closed it. So this is the image. Now in this image, you can see the tooth 1.4 has been extracted. And if you watch closely, you can see the bone is so thin, you can almost see the sinus through this very thin bone in that area. So this is a big defect. We will add a ton of bone in that area. We will also add a ton of bone on the inside of sinus. I will also add, like, this whole thing will get a ton of bone added. Partway when the bone was still being added, so the bone in the sinus is being added, I will add bone here, and then I will close the skin or soft tissues here comes. This is how it looks at the end, at the time of closure. From a technical standpoint, that's amazing because we were able to completely close things off. But the important question is, how does it look? And it looks pretty cool. So we can see this is all the bone that will have, we have enough bone to place a 10 millimeter implant. Like we could place 15 here. So this is how it looks. This is at the time of implant placement. My implants will be parallel to the root of the 1.3, makes me happy. And this is how it looks. The implants are in. Once again, this is how much vertical, horizontal, like buccal bone I will have. Like I have a lot of buccal bone. I'm happy, makes me super happy. Okay, this is simple. This is another interesting case where if you look at this image, doesn't look that bad. It's a simple case. When we place implants, we can have infection around implant. If you look at it, so this implant was placed 12, 15 years ago. Patient comes to me and there is some pus coming from this area. And you see, okay, some funky business is going on. What's the story? We look at the scan and we figure out that there is some bone loss, some infection on the buccal aspect of the implant. So what do? This is how it looks. We look at the X-ray as well. We can see that there is some bone loss beginning in this area. We reflect the gum and we see some calculus, some cement, some nasty stuff in that area. So this is how it looks. We will clean it up. This is how it was. This is how it looks after the area has been cleaned. So you can see the difference. This is some mushy, bad tissue. Everything is clean. You see the bone. This is how the bone looks. So after cleaning. Then what do? I take a piece of membrane. I suture it up with the tissues. The idea is, remember I said I somehow fix my membrane or piece of paper. I don't want it to go haywire. So I attach it to the adjacent area. Then Once it's been fixed, I open it up to pack bone on the inside, and then I will put the membrane back, knowing fully my membrane is not going anywhere, it's already fixed. So I've added bone, then I will put it back. Now I've put this back, I will suture it up. It was, the image was taken when I was almost done with suturing. Some suturing was still needed, but this is what we did. And when you look at the x-ray, wow, looks like after 7 months, 8 months, we've got quite a lot of bone in the area. Makes me happy. Wow, CT scan even shows me that there is bone all around, which makes me happy that, looks good, and the implant should be fine. Again, this is the buccal aspect. This is where the lip area is. This is the buccal aspect of the implant. This is the palatal aspect. So the implant is covered nicely with bone, not a problem. But let's see how it looks clinically. This is what we had, and now this is how it looks. No pus, no infection, nothing. In fact, if you watch, we were able to partly even cover the crown. So in this case, if you look at the original, the height of the crown was much longer. It's still longer than the adjacent, but we were able to slightly cover it. Typically, when you do gum grafting or whatever, you cannot cover the crowns, but we were able to cover even a little bit of crown here. Looks pretty good. Now, before I end, I'll use a couple of cases quickly. And these cases are what, basically these cases will show where we are at these days. What is happening in the world of implant dentistry. We want to do things using surgical guide. Now, this is a simple case. In this case, the guy is a very nice guy, really good patient, but slightly different type of guy. He came in, was referred for problem with tooth number 1, 2, and 2, so the lateral incisors. And I discussed with him. I said, you know what, there is not enough bone. I'll extract the teeth. We want something like, it's an aesthetic area. So I'll give you a flipper or whatever, and looks at me and says, no, I don't care. I don't need it. Do whatever you have to. I don't want anything temporary. I don't want a flipper or something. Okay. So I extracted 1, 2, and 2. I removed them. I added a ton of bone and let it heal. So 6 months later, before the time of implant placement, he comes in, and this is how it looks. So you can see that the patient is missing tooth hair. Missing tooth hair doesn't bother him. So if it doesn't bother him, doesn't bother me. What do I do? In a case like that, the roots were slightly converging of the adjacent teeth. My fear was I didn't want to hit the implant. So what did I do? I took an impression of the patient, and I took a scan. I send it, and we were able to overlap the impression. With the impression, you can make a model. And what you do is you take the model and you take the scan and you somehow overlap them. If you overlap them, then you have a very sort of perfect, nice structure in the computer with which you can play, and you can plan the implant and everything like a video game playing on the computer. So this is the image the final image that you get, and you plan, this is where my implant will come out. And this is where my implant at the other area will come out. Then I want to make sure that I don't make a mistake. So what do? I somehow connect my laptop or my thing with a 3D printer, and that somehow magically prints a structure out, which you'll be able to see, and that makes sure that it has perfect circles. My drills go in there. The chances of making mistakes are reduced. So this is while I'm planning on my software. It looks a little complicated, but let's just look at this area. If you just look at this section, this is my implant, and the boundary on the side tells me that I am about 1.5 millimeters away from the adjacent tooth. So when you place an implant in the ideal world, you want to be about 1.5 millimeters away from the same thing. So I'm about 1.5 millimeters away from the adjacent tooth. So that tells me I'm happy, I'm safe. But that also tells me it's a very tight space. It's slightly less than 1.5, but nevertheless. Similarly, the other thing I see is on the buccal, so this is the buccal aspect, this is the palatal aspect, and my implant is in, I have on the buccal, I kept, I think, 2.5 or something. So I have enough bone on the buccal aspect. Makes me happy. This is another image showing that my implant at 1, 2, and 2, 2. This is how the implant will be. Same thing for the other side of the implant. We have enough bone, makes me happy. And this is how it looks clinically at the time of implant placement. Once I'm ready, I have my 3D guide or whatever you want to call it. I take an image, I look at the area, we can see looks pretty good. This is another image. This is part of planning, makes me happy. There is enough bone on the buccal aspect of the implant. This is how the guide looks. Now with this guide, I will drill through this hole and this hole, and I shouldn't be saying, but the idea is you can do it without making a lot of errors. This is another shot. And through those holes, I just simply went in there and placed those implants. Simple. Zook, zook. Go in there, place the implant, place the implant. One thing I always like to do, and this is an image showing, once again, I have enough bone on the buccal aspect. So if you look at this image, for example, I can see with my probe, I'm taking a measurement. There is 3-4 millimeters, maybe 4 millimeters of bone on the buccal aspect of the implant. We need ideally 2. This is more than what I need. I'm happy. This is at the time of closure. Simple case, easy case, interesting case, makes it awesome. This is another. So if we want to do it in a case where the whole jaw gets the same treatment, this is how you do it. You somehow take the impressions, you play with the video game, which is basically software, and this is what you see. This is one type of image. This is another image. Now in this case, if you look at this thing and this thing, these are all vital structures. You want to stay away from them. This is my planned implant. These are all planned implants. And we have created a zone of safety around these implants. So during planning, this helps me know how far I am away from the important vital structures. Okay, same thing here, same thing here. Makes you more comfortable knowing where my artery is, where my nerve is, how my angulation would be. And this is how it looks. Another image. So this is the blood vessel. This is the area where the nerve or the blood vessel will be coming from in the mental area. What do? We use all this information to make 2 guides. This is my first guide. In the edentulous, it's slightly more complicated, but to make it simple to understand, we just make 2 guides. Just like we made a guide in the last case. We make 2 guides. This would be, no, where's my cursor? Oh, here it is. This is my first guide. I will put this guide in the edentulous case in the lower jaw. Then I will drill through these 3 holes inside the bone. Idea being, imagine when you have teeth, there is something rigid, something fixed, something immobile, it doesn't move. But if you have no teeth, you have soft tissue, it can move. So there is no fixed reference. So what you do is you start off with this guide. You put it in the mouth, you drill through these holes, and you put these pins, 3 pins that you see here. You use this drill and you drill through these 3 holes, then you put these 3 pins in there and you fix this first guide in the lower jaw. Now it's fixed, you're happy, it's done. What you do next is you remove this guide, and because these guides are duplicate, you remove it, you put the next guide in there, and ideally same 3 pins, and these holes, because they're duplicate, same 3 pins should go in the same 3 holes and fix this guide there as well. Okay, so in simple terms, we use the first guide to help us put the second guide in place of the first one, because the second guide has the holes which we will use for the implant drilling. So to make it simple, first guide is there to help us identify 3 holes. Remove the first guide, put the second guide in, use the same holes that we have already created, and the same pins to fix the second guide, and then start using these top holes to just place the implant. Simple? Okay. Patient comes in. I've already put my first guide and I've created these small 3 holes, and through these 3 holes, I've already put the 3 pins so the first guide is stable. Next, I will remove this structure. I will put the second guide in which, so this is the case. If you watch carefully, the second guide is already in. These 3 pins are making sure that the second guide is fully stable. It doesn't move. So this is the second guide. If you watch closely, the second guide has some holes on the top as well, which will be where my implant will be. I'll use these for implant placement. And then I start my drilling. I'm happy with my second guide. Second guide is fixed. I just drill, and then I reflect the flap. I just continue drilling, drill a lot. This is just before I place my implants, just to be sure that everything is going according to plan, because there can be errors. Once I'm happy, I had already opened up the gums. I'm looking at things, make sure I'm not hitting any blood in any artery or anything, and just checking things before I place my implants. This is at the time of implant placement. So the implants go in. Implants are already in. I will suture it up, call it a day. I think that's pretty much it. This is just the final radiograph. This is completely based on the computer CT scan, whatever. And we did something similar in the upper, but that's for another day. That's pretty much it. Any questions? That was it, yes.
Any questions, you guys? That was awesome. Lots of detail, and I love it because then they can really visualize everything and understand.
Yeah, no, I really enjoyed, and I'm grateful that you folks gave me the opportunity. And if you have any questions now or even later, not a problem. You can always just shoot me an email, and I'll be more than happy to answer.
No questions, you guys? Oh.
Yes, please go ahead.
How long is the recovery usually after one of those direct sinus lifts? Is it a while?
Typically, so the image that we saw, one image that we saw was about 3 weeks after, I would say. So what I tell my patients is, for a sinus lift, I would tell them the normal precautions. In terms of pain and discomfort, very manageable. In fact, I would say in most cases, discomfort-wise, it is much less painful compared to a different type of gum graft. From a pains perspective, less invasive, but a few extra precautions. For example, I would tell the patient, please make sure you avoid air travel for about 2 weeks or 3 weeks, because sometimes there can be a perforation, or whatever the reason, there can be some pressure and pain associated with air travel. But in terms of pain, typically not a big problem. Not a big problem.
Awesome. Anybody else?
Oh, sorry.
Yeah,
So you said that, I believe you said that you usually use like a 10 millimeter implant. Is that correct?
yeah, so typically in sinus, I would like to place a 10 millimeter implant, but now with the newer implants, there is a good body of literature, Annabelle 2011, for example, where they have shown that SLOT 2014, that even shorter implants, let's say 4 millimeters. In Canada, we don't have 4 millimeter implants approved yet, but 6 millimeter implants, for example, Straumann has an implant, they are really good as well. So if you look at old literature, they avoided the use of shorter implants because the surface was different. It wasn't as rough. It wouldn't bind with the bone as strongly. With current generation of implants, even if we have a 8 or a 6, it's good. Not a problem.
Okay. Thank you.
No worries. No worries.
I'm just scrolling through everybody to see if anybody else has anything to say. No questions.
Okay.
Everybody really enjoy that? Yeah, it was really good.
Thank you. Thank you.
Thank you very much. We really
No, my pleasure. Super grateful. And if you have any questions or like, down the road, if you want to talk about anything like a gum graft or whatever, let me know and I'll be more than happy to do that.
Yes, I'll send out your email too as well to them, just in case they have any questions.
Sure.
If that's okay.
Absolutely. Absolutely.
Again, thank you for your time. We
My
really
pleasure.
appreciate it.
My
Awesome.
pleasure. Thank you.
Thank you very much.
Take care. Thanks, folks. Have a good one. Bye.
Bye.
Bye.